The next topic we're going to take on is anxiety disorders. And to make it a little bit easier, I've broken up these videos into 3 parts. Part 1 will provide an overview of anxiety disorders and also talk about the symptoms, epidemiology, etiology, and treatment of specific phobias. In the second video, we'll cover panic disorder, and in the last video, we'll cover agoraphobia and generalized anxiety disorder, or GAD. So let's go ahead and get started. Before we dive into symptoms, it's important that we clarify just what we're talking about when we say anxiety, because there are a lot of misunderstandings about it. So first of all, it's important to recognize that fear and anxiety are not the same thing, because in many cases, fear can be quite adaptive. It can signal when situations are unsafe, it can help us remain vigilant, and because of how fear affects our autonomic nervous system, it can also allow us to be physically prepared to fight or to flee. So fear in and of itself isn't the problem, but excessive fear, which impairs functioning, which we might call anxiety, can be problematic. Now let's turn to some general considerations relevant to anxiety. First, symptoms of anxiety often start relatively early in life, certainly by the teens or the early 20s, and there's a lot of different thinking about why this might be, including the fact that evolutionarily speaking, people are more vulnerable when they're younger because they have fewer defenses. So the fact that we develop anxiety symptoms earlier in life might be an evolutionary adaptation that's carried over. Younger people are also more highly influenced by caretakers than older people, so if our caretakers are modeling anxious responses, we might be more likely to learn those. Finally, younger people also have underdeveloped coping skills because they simply haven't had enough experience to figure out whether they can cope with things and also the best way to cope. Second, anxiety disorders are diagnosed twice as often in women as they are in men. Again, there's a number of reasons why this might be the case, including the fact that males tend to underreport. There may also be a biological difference that make women more susceptible, or again, evolutionarily speaking, women may be more prone than men to experience fear and anxiety so that they remove themselves from harmful or dangerous situations more quickly. Finally, anxiety, like many other disorders, have a waxing and waning course over the lifetime, meaning that the symptoms come and go. They're not always there. But symptoms do typically remediate substantially as people age, so the proportion of people over the age of 65 with an anxiety disorder is actually fairly low. One other important consideration before we get into the diagnostic criteria is that anxiety symptoms may be due to one of the primary anxiety disorders, which include separation anxiety disorder, selective mutism, specific phobias, social anxiety disorder, panic disorder, generalized anxiety disorder, and agoraphobia. Or anxiety could be secondary to a number of different things. So anxiety could be secondary to substance abuse, which we would then call substance-induced anxiety disorder. It could be secondary to a medical condition, which we would call anxiety disorder due to a general medical condition. It could be secondary to another psychiatric condition, or secondary to psychosocial stressors, which we might call adjustment disorder with anxiety. For the sake of this class, the disorders you should be familiar with include specific phobias, panic disorder, agoraphobia, and generalized anxiety disorder. So let's dive in and first talk about specific phobias. Now, the diagnostic criteria for specific phobias may feel a bit daunting at first, but we'll go through them step by step so that it'll be more manageable. The first piece is marked fear or anxiety about a specific object or situation. Now, the feared object or situation can be virtually anything, but there are some that are more common than others. So some particularly common feared objects or stimuli are things like snakes, which we call ophidiophobia. Blood itself is called hematophobia or trypanophobia if the fear is about needles or giving blood. Fear of elevators is really common, but it doesn't have a name, though we do have the word claustrophobia to be about fear of small spaces. Acrophobia is fear of high places, and one of the less common but more interesting ones, I think, is coulrophobia, which is fear of clowns. Although there's considerable diversity in what can serve as the targets of phobia, they do tend to cluster around one of several categories. As a result, the DSM-5 phobias are specified as falling into one of 5 groups: animals, the natural environment, blood, injection or injury, situational, or other. The next diagnostic criteria for specific phobias is that the phobic object or situation almost always provokes immediate fear or anxiety, meaning that when the person is exposed to the feared object or situation, anxiety symptoms will result. And we can think of these symptoms as falling in one of three categories: physiological symptoms, emotional or psychological symptoms, and behavioral symptoms. Physiological symptoms can include things like rapid or irregular heartbeat and breathing, palmar sweating, dry mouth, dilated pupils, or muscular trembling. Emotional or psychological symptoms could include things like sense of worry, concern, or apprehension, feelings of fright, dread, or terror, and an inability to concentrate. And behavioral symptoms could include flight, disorganized speech, and motor incoordination. In an effort to avoid these symptoms, the person then actively avoids the feared object, or, if unable to avoid, endures being around the feared object or situation with intense fear or anxiety. Next, the diagnostic criteria for specific phobias stipulates that the fear or anxiety is out of proportion to the actual danger posed by the feared object. And this is a really important piece of the diagnostic criteria, because if the feared object is actually dangerous, then it's adaptable to be extremely afraid or anxious about encountering it. So in the case that the feared object actually is dangerous, then we wouldn't characterize the symptoms as a specific phobia. It's only in those circumstances when the fear or anxiety is out of proportion to the actual danger posed by the feared object that a diagnosis of specific phobia becomes appropriate. Next, that the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. And finally, that the fear, anxiety, or avoidance causes clinically significant distress or impairment in functioning. In terms of the epidemiology, or the incidence of specific phobias, most recent data suggests that about 15% of the U.S. population meets diagnostic criteria for a specific phobia. Now, it's important to note that this doesn't mean that 15% of the population has a diagnosis of specific phobia, but that if we looked at their symptoms, they likely would meet diagnostic criteria for the phobia. As is the case with most types of anxiety disorders, the onset is typically earlier in life, and women are about twice as likely as men to have symptoms. Regarding the etiology or causes of specific phobias, research has provided the most support for two different theories. First, there's some evidence that genetics may play a role in specific phobias, as specific phobias run in families. However, learning has also been shown to play a role, and the most popular learning theory about specific phobias is the two-factor theory. As we've talked about in class before, the two-factor theory has been used to explain the development of specific phobias, with phobias first being conditioned by linking an anxious reaction to an otherwise benign stimuli. And then, because the person begins avoiding the feared object or situation, the person does not experience the anxiety, which ends up reinforcing the avoidance behavior, and therefore the phobia. Finally, in terms of treatment for specific phobias, two primary approaches have gained the most support. The first is exposure therapy, in which the individual is literally exposed to the feared object or situation so the person can unlearn the anxious reaction. We'll look at an example of this in class, but typically speaking, people are gradually exposed to the feared object or situation so they can learn that their anxiety is not necessary. Second is systematic desensitization, in which relaxation training is paired with exposure to gradually desensitize the person to the feared object or situation. The steps to systematic desensitization include first teaching the clients relaxation techniques, and next creating an anxiety hierarchy with the client. An anxiety hierarchy is a ranked list of exposures to the feared stimuli or object from least anxiety-provoking to most anxiety-provoking. So, for example, if a person had a fear of dogs, the least anxiety-provoking exposure might involve reading a book about a friendly dog, followed by looking at a picture of a friendly dog, followed by watching a movie about a friendly dog, followed by watching a dog walk past a window, followed by being outside with the dog about 50 feet away, etc., all the way up until you get to petting the dog. After that anxiety hierarchy has been created, then you put the first two pieces together. You gradually expose the client to each step of the anxiety hierarchy, while also encouraging them to use the relaxation techniques if their anxiety arises. And clients step up or move on to the next, more anxiety-provoking stimuli only when they're able to be exposed to the previous stimuli without feeling an appreciable increase in anxiety. So that's your intro to anxiety disorders, as well as the coverage of specific phobias. We'll move on to the next topic, which is panic disorders, in the next video.